This conference will now be recorded.
Okay, welcome everyone again after the record. And let's see some collection of the questions, some collection of topics that are important in 2023, this year. Okay, so let's have a look. The first question is one of the old but gold took articles, and you know that there is patch guideline for the syphilis as well. Okay, so the question says, which one is more highly infectious syphilis? At which stage? What do you think? At the primary or secondary or late? In the primary, yes, well done. So answer is primary. Okay. Okay, my friend. So a question here, answer, okay. It's about MI in pregnancy. This scenario speak about a patient who had MI, okay, and what is the management plan for delivery. The very commonly repeated question was asking about when would you advise a patient to have delivery after MI? So the answer was, what do you think? 1 week, 2 weeks, 3 weeks, or 4 weeks? What do you think the answer should be? 2 to 3? Yes, 2 to 3 weeks. Okay, so my question here, guys, what do you think about the management during delivery? Now he's asking you about the management of delivery. Okay, so it's not about the induction of labor or not, it's about that how to manage the delivery itself. Okay, what is the advice? So this patient will be for vaginal delivery or cesarean section. Or the question here, is the vaginal delivery allowed? Yes, vaginal delivery is allowed. Cesarean section will be for obstetric indication, or if the patient had severe implication, because not all the patients with MI are the same. Some of them already they have complicated problems. Okay, so it's according to the individual, but vaginal delivery can be advised. Okay, okay. So if you want to induce delivery, or if you want to wait for a spontaneous delivery, is induction of labor contraindicated? What do you think? Not contraindicated, and that will depend on the favorability of the cervix and the Bishop score and the fetal well-being, of course. Okay, so is epidural analgesia contraindicated or not? This is a question that we need to ask ourselves. Epidural safe or not safe? Why not safe? What is the problem with epidural? Yes, it's according to the whole scenario, but it's not contraindicated, right? So it can be applied. Good. So please take care. This is a cardiac patient, okay? And for the cardiac patient, there is some rules in delivery, like the presence of some cardiologists in the hospital, high risk delivery, of course, and continuous fetal monitoring. And how about the second stage? Second stage, we will try to avoid prolonged second stage, right? Delayed pushing, delayed Valsalva maneuver in the second stage of labor to optimize the cardiac output, okay? Avoidance of excessive effort according to the NEHA class. So 3 and 4 will need short second stage of delivery. Take care of the fluid intake. Prevent volume overload. right? Okay, so from the options here, my friends, for the delivery, he told you induction of labor or spontaneous labor, or induction of labor was cut short second stage, or induction of labor was cut short second stage with epidural, or induction of labor was cut short second stage with restricted epidural, or cesarean section. Which one you think that would be suitable for a patient who had MI? Okay, so the question now, shall I choose C or D or E? Because most of you advised that we cut short to the second stage. Epidural is advised, right? Is that correct, guys? To make your patient comfortable, okay? Allow you also to apply the instrumental delivery on time to shorten the second stage. So, well done. So answer is D, yes. Okay, we move to a next question, which is very easy question, asking you about the ARCP outcome, my friends. So ARCP outcome in a patient who had failed MRCOG part 1, but attended all her skills. The question here, what is the outcome of this girl? 1, 2, 3, 4, 5. Okay, I'll tell you guys very important advice here. I'll tell you that actually to answer the outcome correctly, you have to see, okay, how many times this trainee failed the exam, what was the level of that trainee, my dear friend, okay? Why? Because part 2 is essential in higher level, or not in higher level, actually in middle grade registrars, okay? But part 1 exam is essential for ST1 or 2, ST2 from the training, right? And they will never pass to ST3. I'm sorry for the background noise. I can't avoid it, guys. I'm sorry. It's some maintenance and things outside. Okay, so my dear friends, I would like to go for the outcome with you. Okay, we will enumerate the outcome together of the ARCP. Just give me 1 second. Okay, so hopefully that this is a little bit better. So my dear friends, the ARCP, as you know, what they stand for? It's an annual meeting for trainees, for people who are in training, right, for the trainees. And in this meeting, they will do assessment of progression, right? Okay, so people after this assessment, and this assessment will be attended by whom? By the supervisor, educational supervisor, right? Could be the dean, someone from the deanery of training, right? And it could be also attended by the clinical supervisor. Okay, so the panel will sit together and they will decide after they revise what the evidence that being given by the trainee, whether they progress to the next training year or not. Okay, so outcome 1 means that the trainee was excellent, right? Everything was fulfilled and the trainee had gained all the competencies and the standard in the training year, okay, as described in the RCOG training matrix. So this is excellent candidate. This will pass to the next training year or not? Of course, yes. Okay, go to the outcome 2. What is the outcome 2? Outcome 2 is signify that development of specific competences are required, but additional training time is not required. So they will not give additional time for the trainee. Okay, they will just write advices. Okay, and this will enable the postgraduate dean to ensure that the trainee's next attachment will be appropriate to achieve the necessary training opportunity. Okay, so they will give advices for improvement. Okay, and outcome 2 is not a failure because the trainee still can go to the next training year, right? Clear this part? Okay, so what outcome 3? Outcome 3 is issue of outcome 3 means that you will offer or you will ask the trainee to obtain specific competencies with additional training time. With what? With additional training time. So if I have ST1, passing part 1 MRCOG is not necessary to pass to the next year. Is that correct? Is that correct? If she is ST1, it's not mandatory for her. But if she is ST2, it's mandatory to pass to ST3. So ST2 of very important year in the training. Why? Because they must finish part 1 MRCOG in order to be second on call and move to the ST3 level. So in exam, with the insufficient information given from the recall, I will advise you the same, guys. Number 1, take care what was the level of trainee. If the trainee is ST2 now, this is her ARCP. She had failed MRCOG exam part 1 once. She developed all other competencies. What do you think the panel will decide for this patient? For this trainee? Everybody is patient nowadays, I'm sorry. They will decide 3. They will decide that she need more time. Excellent. Okay, so when additional training time is needed, okay, and this is her first time, they will offer her the chance. Okay, so it's outcome 3. But be careful, the exam can be tricky. The exam can give you ST1, so be careful. Or can give you that she had many trials, 3 or 4 trials of part 1 MRCOG exam. Means that she have been seen before, they given her additional time before, but she failed to pass despite of 1 year of additional time. Okay? Clear, my friend? Okay. So this trainee who had in this year additional time and outcome 3 to finish her exam. Next year, she came. How are you doing there? Not very good. Why? I failed the exam so many times. Okay, so now you have finished 1 year of training, of the additional time and training, and you didn't achieve the requirement. What they will do now? What they will do now? They will release her from the training program. This question specifically is very old question and repeated. That a trainee so many times appeared in the exam, okay, and she had difficulty to pass it. She had received additional time before, but still she didn't do it. What is the advice now? Release from the program. What is release from the program called? This is ST. This is for the patient for the again patient, I'm sorry, for the trainee who is ST2, given additional time, 1 year, she didn't pass her exam, part 1, so release from the program. This is called outcome 4. Okay, this is called outcome 4. How about outcome 5? Outcome 5 is reserved for a very small number of cases where the panel can make no statement about progress or otherwise, since the trainee had supplied either no information or incomplete information to the panel. So for some reason, the trainee not there. For some reason, okay, the trainee didn't apply the information to the panel or didn't appear in the meeting. So now, what is the outcome? This is 5. They can't make progress. Dear friends who are asking questions while we discuss, okay, you don't listen. So that's mean you are missing very important information. Everything will come, okay, in the explanation. Please, guys, ask at the end, kindly. So my friends, again, revising the outcome. For the ARCP, the annual meeting for assessing of progression of trainee. This very important meeting that happen each year, okay, in the months before ending of the training year, okay? So what happened in this meeting? There will be a panel sit together to assess the candidates, right? The trainees. They will give them outcome after they review the evidence, after they review the workplace assessment tool, the competencies, and everything required to pass this year. How to know what is the requirement? The requirement is simply, okay, published on the RCOG training matrix, okay? So the trainee in this particular year must fulfill the requirement in the matrix so he can move to the next. What is the training year in the UK? Start from ST1 to ST7. So that's mean at each year there is a specific exam they need to pass? The answer is no. There is some particular years of importance in their life to pass exam. Other years it will be pass competencies, okay, or prove that they have these competencies by the workplace assessment. Year 2, ST2 must pass Part 1 MRCOG. Okay. ST5 must pass Part 2 MRCOG. And in the training competencies, actually Part 3 is there, but Part 2 is something that they will never negotiate. ST5 must pass Part 2. Okay. Part 3 is also included in ST5. Okay. Okay. For you, for this exam, if you are not in the training in the UK, this question is very strange for you. So how to answer it? Simply, you should know the basic information about the ARCP. All the information are on the RCOG website. If you don't have now time, so at least revise the important notes at this one that we discussed today. Okay, guys? So please be careful. There is one classification of ARCP which show that the ARCP from 1 to 8, this one stopped, the RCOG stopped using this since 2019. So people who still use it, it's old. Now the ARCP outcome are 5 only. Okay? For the trainee who couldn't apply for the ARCP, she didn't attend the meeting because of maternity leave. What do you think her outcome will be, Dr. Delhi? It's 5. Yes, it's 5. Okay? So I had all of this meeting to discuss this question today just to clear your concepts, guys. Okay? Because I have seen you have mentioned me in this question, okay? And it's outcome 5. So I need you to be clear about this. ST2 and ST5 as a special outcome years. To progress from ST2 to ST3, trainee should have passed part 1, completed the basic logbook competencies, completed the OSAT, listed in the matrix of educational progression, confirming that they have the skills to work second on call in the obstetric and gynecology. To progress from ST5 to 6, they must have at least part 2 passed. Okay? And it's preferable also to have part 3. Completed the core section of the logbook, completed the basic ultrasound module, undertaken the appropriate training in sexual and reproductive health, okay, and completed all the OSAT listed in the matrix to show evidence of the clinical competencies required to move to ST6. ST6 is advanced level in the training, okay, so they must have passed all the basic requirement. Okay, guys, I hope that this is clear. Please take care. When you read the scenario, please take care. What is the training year? Okay. And what happened exactly? And then give outcome from 1 to 5. 5 is for special scenarios like sickness or leave or family issue, family emergencies, or anything that prevents the trainee from appearing to the panel. Okay? Okay. So another question from the TUG article. Thank you, guys. If you have any questions, guys, please write it down. If you want to ask anything about the previous one, please let me know before we move to the next question. Outcome 2, Dr. Noha. Okay. Outcome 2, dear, is someone, you give them advices, okay? Advices about their competencies. Their competencies are complete, but you need more quality. Okay, so they have everything fulfilled according to the training matrix. Okay, but they still advise to develop more competency. Look, my dear, for the part 1, because we don't want to spend time more than this, okay, for the part 1 MRCOG, how many exams in 1 year officially? Actually, it's 2. September exam is something that exceptional, okay, but anyway, it's 2, January and July, right? Okay, so you have a scenario says a trainee presented to the meeting to the ARCP, couldn't pass part 1 MRCOG, then given time, then again presented, okay, after failed 3 attempts of the MRCOG part 1. That's mean he came after failed 3 attempts. This is 1 year or more than 1 year? This is more than 1 year, right? Or at least 1 year if you speak about the COVID time. Okay. So what is the action now? If he is ST2, what is the action now? It will be released from the program. Yes. Okay. Good. What outcome that have the release from the program? It's 4. Yes. Good. Guys, the ARCP questions should be now more easier than before. Before it was 8. Now it's only 5 outcomes. Okay? So just try to remember each one. One is for a competent candidate who did everything very good, brilliant. So move to the next year. This is outcome 1. No problem in this candidate. One that failed to appear or to provide information for specific circumstances. So the panel will not be able to make any statement. This is called outcome what? If they can't make a statement because the information is not there. The subject of the meeting is not there. This is outcome 5. Okay, in between you have 2 and 3 and 4. 2 is someone who completed everything but need more development in some area. Okay? So he will still move to the next year, no problem. Right? 3 is someone who have one area missed and he need time to finish it. What? Yeah, extra time is needed. So what outcome is that for extra time needed? That's 3, straightforward. Excellent. Okay. Someone who have been given, offered time before, and this time is 1 year, up to 1 year, but still he didn't finish. Yes, it's 4. 4 means bye-bye, released from the program. Okay? Okay. So next topic, my dear friend, that we'd like to have a look at is diabetic with retinopathy. What is the time period to do screening in pregnancy? From the NICE guideline, you remember, we provide the retinal assessment before pregnancy if it is not done within 6 months. Then the patient, when she becomes pregnant, she will do retinal assessment at booking unless she had it in the previous 3 months. Then again, if there is retinopathy already, so we will repeat it in the mid-trimester between 16 and 20. Then she will have a third one at 28. So how many times for the patient who have already retinopathy? 3 times. 3 times if the patient already have retinopathy. But for a patient who does not have retinopathy, she does not have pre-existing retinopathy, she is just diabetic and we do screening 2 at booking and at 28. Okay, guys? Remember, we don't only do retinal assessment, we also provide the renal assessment as well for nephropathy before pregnancy, if it is not done in previous 6 months. And then if the patient became pregnant, this will be a booking and at 28. Okay? Yes, Dr. Maisa, if we speak about pre-pregnancy, this will be 6 months. Okay? If we speak about pregnant women, we ask about the previous 3 months. Okay? So how many times? For a patient with retinopathy already? Patient with retinopathy already is 3. Excellent. Well done, everyone. Well done, my superstar. The timing are booking 16 to 20 and then at 28. Okay. How about the patient who have treatment of retinopathy? Do you remember from yesterday's discussion? We have said the patient with retinopathy, she will have treatment by the laser photocoagulation, right? Good. So how many months after the laser photocoagulation this patient will be allowed to be pregnant? I'll tell you, 1 year, 2 years, 6 months, 3 months, immediately. Are you sure, guys? Are you sure of that immediately? Okay, so I'll tell you guys, if we allow the patient to have immediately pregnant, okay, to go immediate for pregnancy, do you think that any changes during pregnancy can affect her treatment already? Or pregnancy had no effect? Yes, of course it will affect. Okay, so let's have a look, guys, on that TUG article, because again, appears it's important for your exam and it's recently become important. So they will tend to repeat questions from this TUG article in your exams. This is a lesson that we need to learn. Okay, so regarding diabetic eye disease, from the TUG article of ocular manifestation of pregnancy, okay, so they said pregnancy is independent risk factor for progression of diabetic eye disease, and therefore individuals with pre-existing diabetes should have digital photographic screening after the first antenatal appointment. If it is normal, then this will be repeated at 28 weeks, but if abnormal, another assessment should be made at 16 to 20 weeks of gestation. So for the abnormal or the patient who had pre-existing retinopathy, this is 3 times. Okay, normal patient and only screening, this is 2 times during pregnancy. Okay, this is answer for your exam question. More frequent examination is recommended according to the severity and likelihood of rapid progression. It's important to note that the presence of diabetic retinopathy is not contraindication for vaginal delivery regardless of severity. Okay, diabetic retinopathy is classified either non-proliferative diabetic retinopathy, which is subdivided into mild, moderate, or severe, or proliferative diabetic retinopathy, which has the retina develops abnormal new blood vessels. In pregnancy, there's a risk of progression to retinopathy, for example, from moderate to severe, or even to proliferative stage. So it gets worse with pregnancy. Diabetes in early pregnancy show that pregnancy, this is a study that showed that pregnant women with little or no diabetic retinopathy before or at the onset of pregnancy are unlikely to have significant progression of retinopathy, and mild progression occurs in 10 to 20% only. Okay, while the severe, they have 55% progression. Do you remember this number? This is a very important number from the TUG article pool. Okay, guys, if it is severe already, so it will be affected by 55%. Development of proliferative disease only at 6.3, okay, from mild and up to 30% to severe, from moderate to severe. Okay, okay. So understanding of the effect or the problem of pregnancy on the diabetic retinopathy is very important. Okay, that's very, very important. Okay, so how about a patient who received the treatment already? Shall I allow her, or shall I give her 3 months before conception? Shall I allow her to go for pregnancy right away, or I will give her some time? Okay, so please give her 3 months. Okay, no problem. We learn. This is lesson to be learned. Okay. Okay, so this is management of the miscarriage, so I'm not going to, comment more on that, but I will comment here, okay, on this question. A patient with diabetic retinopathy treated with anti-VEGF. You know what does this stand for? Anti-vascular endothelial growth factor. Okay, this is what does this stand for? How long to wait to become pregnant? After the last dose, they will be advised 3 months. Okay, after the last dose, they will be advised how many months? Okay, so for now, my dear friend, okay, for now, do you think that before we allow this patient to be pregnant, we need ophthalmologist review? Yes, please. Okay, so if you have option to tell you that wait 3 months, okay, with ophthalmology review, this will be the best option, especially if it's an EMIQ. Okay, so please remember this information. After the anti-VEGF injection, how many months is required? 3 with ophthalmologist review. Okay, clear so far? Okay. A breach sacroanterior below the spine. Now the patient had thick meconium and CTG show variable deceleration. Okay, so what do you think? Breach, thick meconium, variable deceleration. What you will say now? When there is pathological CTG with the breech, please don't continue vaginal delivery unless you have already, okay, the breech is passed already, okay? Otherwise, before the breech passed, please go for cesarean section. Okay, so again, a question about syphilis. So it appears that syphilis has significant importance in this exam. So what is the best time to treat syphilis by which it reduces the perinatal morbidity? What do you think? Before 26 or after 26? Earlier is the better, right? So that will be before. Okay. The question, my dear friends who revised with me the cholestasis in pregnancy, about the orthodeoxycholic acid. How does it help in pregnancy? Yes, well done, my friend. So it has no effect on the prenatal mortality or stillbirth rate. So you think that it reduces the prenatal mortality or stillbirth rate? No, it does not. Of course, no. Okay. So does it help with relieving symptoms in the patient? If the patient had severe itching, do you think that it can help with the symptoms? Yes, so yes, well done. So it even happened in some cases, not all of the cases, but it can help. Okay? So if you want to give the orthodeoxycholic acid for the benefit of symptoms relief or relieving the itching, okay, not in mild cases, please. Okay, there will be no evidence for that. Okay, and you have to tell the patient that this is not going to affect the outcome. Okay, so patient who had severe intrahepatic cholestasis of pregnancy, she will still need to deliver early, right? Okay, so another question in the same exam was asking about the timing of delivery for patient with intrahepatic cholestasis. Okay, so what do you think the timing of delivery will be? Sorry, just here. Time of delivery between 35 to 36, right? According to the bile acid concentration. Okay, so let's have a look, guys, to the algorithm or the flow chart of intrahepatic cholestasis. And remember, this is one of the most recent guidelines. That's mean very important for your exam, right? Okay, so a pregnant woman with itching. I need to look first, normal skin or abnormal skin, right? Okay, if the skin is normal, then I will think about the bile acid level and liver function test. When the bile acid done and came as less than 19, what's your diagnosis? What is the diagnosis if the bile acid less than 19? This gestational pruritus. Excellent. Okay. So if the itching is ongoing, we can repeat the investigation again. But there is no effect on stillbirth, no effect on preterm labor rate, no impact on the birth timing. But if the bile acid concentration found to be between 19 and 39, here I will need, okay, to repeat the investigation from time to time so I can make sure that there is no progression to more severe type. How frequent do you need to repeat the investigation in the mild ICB? 1 to 2 weeks, right? Okay, so if you are in the MEQ and the MEQ says what is the next step after the investigation result came as bile acid concentration, what is the next step? Next step for the MEQ, repeat the test or advise delivery by 40 weeks, history and examination. Excellent, Dr. Ashley, my champion. So, Dr. Rawan dear, please remember, it's structured history is the next step, right? So you can see here, my dear, what is the next step after the result? Dr. Samuna dear, structured history, okay? Structured history is the next step. Be careful, my champions, from the MEQ. You know the information, still you get the question wrong. That's because of the trick of how they ask the question, leading word in the scenario. Okay, so after the history examination and consider other diagnosis, okay, I will discuss with the woman that there is 16% preterm birth rate, that the delivery would be by 40 weeks, and that this mild ICB does not affect the stillbirth rate. However, I still need to repeat the investigation every 1 to 2 weeks to make sure that you're not getting the severe form. Clear so far? Okay. So how about if I tested the woman and I found that she had bile acid level between 40 to 99, like for example 43. What is the diagnosis? Moderate ICB, right? If the moderate ICB increase the stillbirth rate, it does not affect the stillbirth rate until 38 to 39 weeks. So I will advise delivery. It makes sense that I will advise delivery by this time, right? So delivery 38 to 39. What was the exam question about the time of delivery? It was about case of severe ICB. In the moderate, we repeat the test again, 1 to 2 weeks, but in the severe ICB, once you have the diagnosis, okay, and you make sure that there is no other problems, okay, no need to repeat the investigation. Why? Because you already know that this is severe. But what you will advise is early delivery at 35 to 36. Why? Because increase stillbirth risk. And preterm delivery is already 30%, 30%. Okay, my friends? Intrahepatic cholestasis, please revise it. Okay, so we have learned from this year. This guideline is very important for your exam. I hope it's clear. Another question asking about herpes. And herpes in pregnancy, you all know it's very important repeated topic, right? And you need to have a review of the herpes in pregnancy. So dear friends, algorithm for management of herpes in pregnancy and the neonate. Let's clear our concepts. Which one is the more severe in herpes? Primary or recurrent? The primary, okay. The primary, if I asked you, primary in the first and second trimester or primary in the third? Primary in the third, yes. What is the rate of transmission if the lady got a primary infection around the time of delivery? It's 41. So, herpes infection cause congenital anomaly in the neonate. False or correct? False. Okay, the problem is actually after delivery, neonatal disease. Well done. Okay, so if you have a patient, let's have a look here to the algorithm and divide it step by step. If you have recurrent genital herpes, you will treat the episode with a standard dose of acyclovir if necessary. Okay, you will consider acyclovir for 100 mg TDS from how many weeks? From the 36-40 weeks. Well done. Okay. Risk of transmission is what with recurrent genital herpes? From 0 to 3. Excellent. So, vaginal delivery allowed or not? Yes, of course. Okay. So, if the vaginal delivery allowed and the woman was okay at the time of delivery, fine, no problem, then no problem. If there was recurrent episode and the genital lesion was present at delivery, still the patient will have normal postnatal. She will be discharged at home, but we will keep eye on the baby. If the baby is well at the 24 hours, advise parent regarding later management if there is any concern. Okay, so because the risk of transmission is low, however, we'll just keep an eye on the baby. Clear so far? I hope it is. Okay, how about primary herpes, but in the first or second trimester? Is that serious event for you? Are you afraid of risk of transmission to be very high? Actually, if it is a primary in the first or second trimester, you are now away from labor. Okay, so we will treat the episode, the primary episode itself, and from the 36 weeks, we will advise acyclovir 400 mg TDS as prophylaxis. Okay, the patient will have normal delivery or cesarean section at the time of delivery. Why cesarean section, Dr. Aisha? Is it primary around delivery or primary in the first or second trimester? If the primary in the first or second trimester, don't worry, deal with it regarding the delivery as it's a recurrent, okay? So, offer the prophylactic dose from 36 weeks, offer vaginal delivery, and that's it, okay? All the problem comes with the primary in the third trimester, especially within the 6 weeks of delivery. This is the high transmission rate that is 41%. So, what shall I do? I will start the treatment. So start treatment. Okay? Shall I continue till delivery or stop and restart again? You will start the treatment, continue till delivery. Okay? What we will recommend as a mode of delivery? Cesarean section, especially for which patient? Cesarean section for a patient who developed the primary herpes at the time or around the time of delivery. So the nearest to delivery, the highest the risk. Okay? Otherwise, a patient developed in the third trimester but at 29 weeks. Okay? She received the treatment. She is now receiving the low dose and she wants normal vaginal delivery. Okay or not okay? Yes, but in this case, we will take extra precaution for the baby. If a woman who had herpes primary near to delivery and she want to go for vaginal delivery, then please take care of the baby. If the baby is well after delivery, okay, the baby will receive a cyclovir 20 mg per kg 3 times per day for 10 days while awaiting test result. Okay. If the baby is unwell, you will perform a lumbar puncture, okay, for the herpes PCR. Okay, guys? Take care of the baby, management of the baby. They like in the infections, herpes and HIV. Sometimes also they ask about the group B, chickenpox, okay, and herpes, of course. They like to ask about the management of baby after delivery. Okay? So, if the baby is well, mother primary herpes, she delivered vaginally, baby is well, you think baby will need a cyclovir or no? Yes, baby will need a cyclovir. 10 days until the result coming. Okay. The baby of a mother delivered by cesarean section. Receive a cyclovir after delivery or not? No need. Yes, no need. Just keep the baby under observation 24 hours, and if there is no concern, bye-bye. Right? Okay. Good. So, dear friends, for a pregnant patient with intrahepatic cholestasis, bile acid more than 100, what is the recommended time to delivery? "35 to 36. Well done. Okay, what is the gold standard for peripartum cardiomyopathy diagnosis? Gold standard. Yes, excellent. This is the echo. Yes, excellent. Well done. Okay, so my dear friends, another question that we need to have a look at it because, you know, they are touching the updated information. Patient had molar pregnancy. She want contraception, but she doesn't want POB or many pills. What to give for contraception? Patient with molar. A patient with molar pregnancy. Okay? She want a contraception. Okay? So what contraception will you advise? This is my question to you. Okay. So another question, guys, to update your information. Another question regarding hormonal contraception use after molar pregnancy. What do you think? Contraindicated or allowed? Okay. It's allowed. Okay. Not after normal. I'll tell you there. Okay. We used to know this part of information, okay, about the contraception, the hormonal contraception, that we will wait after normalization, okay, to start the hormonal. Okay. You remember, you know this one? Yes, okay. After the update of the guideline of the molar pregnancy, okay, the college wrote in the guideline that follow the FSRH guideline. They wrote this statement only, follow the FSRH guideline for contraception. So what does the FSH guideline says about use of contraception after molar pregnancy? The FSRH says that we can start it immediately. Okay, that hormonal contraception can be started immediately after evacuation. The only method, okay, that will be avoided is the ICD. Okay, so the information from the previous guideline of molar pregnancy is now changed because simply the college, your RCOG, just said that please follow the FSRH. Okay, which method that have hormones in it that I can start after normalization of level? Intrauterine devices. Okay, so let's have a look, my dear friend, to the FSRH guidance. Okay, do you have time? Do you have time to learn this part from the FSH guideline? Okay, so the college is just simply testing that you are updated. Okay, so dear friends, Contraception after gestational trophoblastic disease. Okay, this guideline is released 2017, updated in 2020. Okay, the RCOG guideline also, molar pregnancy, updated in 2020, same year at the time of COVID. They have made these changes. So, when should contraception be discussed or provided? Therapies that provide care to women who have or had gestational trophoblastic disease should give them opportunity to discuss their fertility, intention, contraception, and preconception planning. Whenever contraception counseling is provided, care should be taken to ensure that the woman don't feel under pressure to choose a method of contraception. Women should be advised to avoid subsequent pregnancy until the GTD monitoring is complete, right? Is that correct? Until she complete the monitoring. Effective contraception should be started as soon as possible, as sexual activity and fertility may resume very soon after GTD. Women should be informed that the effectiveness of different contraceptive methods, including superior effectiveness of long-acting reversible contraception, when choosing an appropriate method to use after GTD. Okay, so now can I provide them with LARC contraception? Yes, I can provide them with LARC. Okay, okay. How long should a woman wait after GTD before trying to conceive? The woman should complete her follow-up who had GTD. But if the woman treated by chemotherapy, how long does she need to wait? 1 year after treatment. Yes, both are very important for your exam. Okay. Okay. This part, guys, about the medical eligibility. From medical eligibility, which contraception method are safe to use after GTD? Women should be advised that most methods of contraception can be safely used after treatment of GTD and can be started immediately after uterine evacuation, with exception of intrauterine contraception, but not when there is persistently, okay, IUCD with persistent high HCG or malignant disease. That's why we will be afraid from the IUCD, but it can be inserted if the level became back to normal. Okay, guys. What emergency contraception will be used after GTD? We know emergency contraception, usually the best is the IUCD, but it's contraindicated in this case. So we will go to the oral one, right? Okay, so you have two choices that you go for it. Okay. Okay, so I hope that this part is clear and you have the updated information, guys. So this is a lesson to be learned from this exam. It's already there, but people, when they study, they just, tend to forget or to pass this information unless you have a question like this, make you go and revise. Okay? Okay. So please search about LARC, long-acting reversible contraception method. Okay? That would be suitable for the patient. Okay? Okay. So we still, guys, have more to discuss. Okay? I just ask you for 5-minute break. Can we have 5-minute break, guys? Okay, so I'll see you after the break.
This conference will now be recorded.
Hello, my friends again for the discussion. So, if I ask you what is the incidence of placenta previa at term, so answer is straightforward. It's just a number, 1 in 200 or 0.5%. If we ask what is the best method of radiological assessment of primary cervical tumor, okay, greater than 10 millimeter or invasive tumor. So the answer will be, what do you think, CT or MRI for the cervix? It's a matter of fact that we deal with all the gynecological cancer with MRI, except one type of cancer that we need the CT, ovarian. Excellent. Okay. Yes, correct. Okay, so what is the commonest fetal complication of mother having phenylketonuria in pregnancy? This question from the TUG article of phenylketonuria. So what is the common manifestation? It's a problem neurological, okay? So they have microcephaly, okay, especially in the woman who failed to gain more than 70% of the recommended weight during pregnancy, right? Okay. A patient who is, or pregnant lady who is pregnant with triplet, she's asking you about the screening test for Down syndrome, where the largest CRL was 67 and 62. So what will be the screening at that time? So the choices was maternal age plus knuckle translucency and combined test, or non-invasive prenatal testing, or quadruple test. Okay, so can I use second trimester serum screening for a woman with triplet? No, it's not advised. Okay. Okay, so this part from the guideline, as you can see here as a reference. In this reference, they say healthcare professionals who screen for Down syndrome, Edwards syndrome, Batau syndrome, and triconic triplet pregnancy should map the fetal position, use the knuckle translucency and maternal age to screen for Down syndrome, Edwards syndrome, and Batau syndrome when the crown rump limb measures between 45 to 84. And this will be approximately between 11 plus 2 days until 14 weeks plus 1 day. Calculate the chance of Down syndrome, Edwards syndrome, and Batau syndrome for each fetus. Refer woman with dichorionic and monochorionic triplet pregnancy who wants to have screening for Down syndrome, Edwards syndrome to tertiary level for fetal medicine center. Don't use the second trimester screening for Down syndrome in triplet. Okay, guys? Okay. Next question was actually a repeated one, asking about what is the most occurring risk in pregnancy conceived by ova donation. What is the problem, guys? Okay, so you all answered the preeclampsia. Thank you. So here is a question about gram-negative cocci. You know that the Neisseria, gonorrhea are organisms that are diplococci, but gram-negative as well, right? Another question from the TUG article, okay, of preventing infection. What is the most common bacteria isolated from the surgical site infection? He gave options between Strep, Proteus, Streptobiogenes, Staph. So the group of enterobacteria, right, is the most frequently, right? So the most common causative pathogen isolated are enterobacterial, okay? This is formally include, okay, the enterobacteriaceae, okay? And also Staphylococcus was there, and E. coli was there, Proteus is there, but the most common will be the enterobacteria. Okay, so just give me 1 second, guys. I'm opening the TUG article. Okay, so it's worth review. Okay, so I have seen from Dr. Amal. Dr. Amal, you're saying there was a question from the last exam about gram-positive diplococci. Okay, so what is a gram-positive diplococci? Very famous. Okay, so we all know that the Streptococcus pneumoniae, okay, this is considered as gram-positive diplococci, right? Okay. How about the Enterococcus? Neisseria is gram-negative, Dr. Noha. Okay. How about the Enterococcus? Enterococcus is gram-negative or gram-positive? Okay, so thank you. Yes, thank you. I'll show you guys picture of the E. coli. Okay. Could the E. coli arrange it in diplococci or no? Okay, I want to show you here and here. Can you see it? Yes, why not? Okay, so 1 second, guys. I just told you, okay, that we need to have a look to the surgical site infection, okay? Thank you. For mute. Okay, so let's have a look, guys, to this TUG article, okay, and its summary. This is the surgical site infection in obstetric and gynecology, prevention and management. Okay, so there is criteria for the diagnosis, as you can see, guys. Okay, for surgical superficial wound infection, at least one of the following. Enterobacterium there is the one that's most frequently isolated. I'm answering the question of Dr. Amal when she asked about the gram-positive diplococci. Okay. Now we will have a look to this summary of the guideline, of the TUG articles that published in 2021, because it's important for your exam, so please take care, okay, from the infection. There are specific criteria for making diagnosis for superficial wound infection. At least one of the following are needed. So when they're purulent, okay, or exudate with organism identified, presence of one of the following: pain, redness, localized swelling, tenderness, or heat. So it's a clinical. Or diagnosis of superficial wound infection by surgeon or attending physician. For deep wound infection, at least one of the following will be required: purulent exudate from a deep wound incision, or spontaneous dehiscence of a deep incisional wound, or the wound will be deliberately open in the presence of pyrexia more than 38 with localized pain or tenderness. Evidence of abscess or infection that involve deep wound, okay, found in direct examination of the wound. Diagnosis of a deep incisional wound infection by surgeon, okay? When there is infection that has organ or space, okay, so at least one of the following. Again, exudate from the drain placed on the organ or the space via stab wound, for example. Organism isolated from the organ or space, or evidence of abscess or infection involving the organ or space found on direct examination or by the radiological examination. Diagnosis of an organ or space wound infection by surgeon or attending physician. Wound classification. Wound classification is either clean wound, okay, which is a wound that made under sterile condition. Like which wound, guys? Cesarean, okay. Okay, so there was no pus in the procedure, there was no other body fluids, like, for example, you are opening in the bowel or something like that. Okay, so skin incision for ovarian cystectomy, this is considered the clean. Clean contaminated, this is a wound made under sterile condition, but in which respiratory or gastrointestinal or genital or urinary tract is entered under controlled condition and without unusual contamination, or an incision through which the respiratory alimentary or genitourinary tract is entered under controlled condition but with no contamination encountered, like skin incision at the hysterectomy or cesarean section. Contaminated. Contaminated, it's typically an open, fresh, or accidental wound or incision undertaken during an operation in which there is major break in sterile techniques or gross spillage from the gastrointestinal tract. Like if you are performing a surgery, let's say it's a cesarean section, but bowel is opened accidentally. This is now clean or clean contaminated or contaminated. This is contaminated. Dirty or infected, this is wound with devitalized tissue with organism pre-existing in the surgical field before surgery. Okay, like you are opening already on infection, on abscess or pelvic collection, so it's a dirty or infected. Key point, okay, the SSI, what is the SSI? Surgical site infection is estimated to complicate around 2 to 6% of surgeries in high-income countries. In the NHS-wide audit of SSI, enterobacterials and Staph aureus are responsible for 30 to 22.9 of cases, respectively. So which one is more frequently responsible for cases? The enterobacterials. Okay. SSI complicating abdominal hysterectomies typically involve Staph aureus, okay, Enterococcus, E. coli, or cons. Genital infections such as bacterial vaginosis and infection with Neisseria gonorrhea, Chlamydia trachomatis, or Mycoplasma can lead to ascending infection following transvaginal or transcervical procedure. The organism most commonly responsible for SSI is Staph aureus. After what? Not in general. After what? After cesarean is Staph aureus again, please. So if we ask you in general, in the NHS-wide audit of SSI, what is the most common organism? Staph aureus or enterobacterials? The entero. Okay. After CS, most common surgical site infection? Staph aureus. Thank you very much. Typically, SSI develop within how many days post-operatively? 4 to 7 days. Not every SSI requires treatment with antibiotic. Sometimes minor or superficial infection may only require removal of suture, abscess, drainage, and topical antiseptic. High index of suspicion based on history, clinical examination, and review of vital signs is crucial. Any fever more than 38 or at least 2 occasions, at least 4 hours apart to more than 24 hours after surgery should be evaluated for infection. Okay? Because, my dear friends, sometimes patients develop high temperature after operation, and then after that it will be once, and after that it will be settled. Right? So if we have fever more than 38, 2 occasions, at least 4 hours apart, this is evaluated, should be evaluated for infection. Fever more than 38, more than 1 day after surgery, should be evaluated. What is the surgical site infection reduction bundles? And believe me, whenever there is something called bundles, it's important for your exam in the MRCOG. So to reduce risk of SSI, the element of this bundle include antimicrobial prophylaxis, skin preparation, avoiding hypothermia and surgical drain, and reducing intraoperative hyperglycemia. So glycemic control is helpful to reduce risk of infection. not only the antibiotic. So skin preparation, antibiotic, avoiding hypothermia, avoiding hyperglycemia, and surgical drain. Okay? In case of incidental bacterial vaginosis diagnosed prior to surgery, we advise to treat the patient for how many days? It's incidental. Something that been discovered incidental, but you are going to do a surgery that have this part. So treat for 5 to 7 days. Where's the treatment? In court? Yes, the scheduled surgery. It should be continued to complete the course after surgery. It's, however, not considered as contraindicated. So the woman can, if had surgery after 2 to 3 days, she can complete the antibiotic after. Wound cleaning should be done with sterile saline for up to 48 hours after surgery. So what is the recommended thing that we use, or the material that we use to clean the wound? Is it betadine? Is it chlorhexidine after the surgery? Okay, or sterile saline? Sterile saline. Okay, so after how many hours after surgery patient can have a shower? 48 hours. Okay, if there's complication of wound, okay, then it will be also used. Okay, tap water can be used to clean the wound after 48 hours. What do you think? Can I clean with tap water? Yes. Following hysterectomy, the common SSI of vaginal cuff and pelvic cellulitis and pelvic abscess. Okay, so the site of infection after hysterectomy. Start from vaginal cuff infection, pelvic cellulitis, and pelvic abscess. There was a case of the exam about vaginal cuff infection, hematoma and infection. So vaginal cuff cellulitis might not require antibiotic treatment because it's sometimes self-limiting. For patients requiring antibiotic, penicillin-based preparation such as co-amoxiclav is usually sufficient, or clindamycin for those who have penicillin allergy. Okay, my friends, so if the patient have vaginal cuff cellulitis and require antibiotic, what type of antibiotic you will advise? Be careful. Again, every antibiotic is important. Every medication is important. So co-amoxiclav. If the patient has allergy, clindamycin. Remember, clindamycin can be given to a patient with penicillin allergy, but not in all infections. Do you remember group B? Can I give clindamycin if the patient had allergy to treat or to prevent group B? No. Why? Because the group B have resistance against clindamycin, right? Okay. Superficial incisional surgical site infection in the form of wound infection is most commonly caused by Staph aureus and present as cellulitis. Okay, so if I ask you about what is the most common organism that cause superficial infection or cellulitis, it's Staph aureus. Try to remember fluoxacillin. Fluoxacillin. Do you remember the breast problem, breast infection, mastitis, when they are bacterial and require antibiotic? What antibiotic you give? fluoxetillin. I want to change the color. Why it's not allowed? Okay. If the patient had allergy, clindamycin or vancomycin. How about deep surgical site infection, such as pelvic cellulitis? This is not vaginal cuff cellulitis, this is pelvic cellulitis, with lateral extension of the vaginal cuff cellulitis into the parametrium. So it's a complicated vaginal cuff cellulitis and pelvic abscess formation. So surgical exploration of the wound and drainage of abscess, as well as peritoneal saline wash and the insertion of drain. Okay, guys, for the deep surgical site infection and pelvic collection, what you will do: exploration, surgical exploration, drainage, wash, drain. Okay. How about necrotizing fasciitis? It's an uncommon infection, right? Surgical site infection that has been reported in 1.8 in 1,000 cases following cesarean section. It's commonly caused by polymicrobial organism, aerobic, anaerobic, or mixed. The organism most commonly associated with cesarean section and gynecological surgery is group A, streptococci and coliforms. Okay. Type 2 necrotizing fasciitis is common in patients with immunosuppression, diabetes, or vascular insufficiency, or chronic alcohol, or who are undergone transplant or on steroid. The mainstay of treatment is antibiotic, and this because it's a polymicrobial. Remember, we will give combination of antibiotic such as penicillin G and aminoglycoside. Okay, if the function, renal function, normal, you give aminoglycoside. You can use clindamycin and surgical debridement. This is different recommendation regarding prevention of infection. Okay, which one we will follow? Look at the NICE recommendation. Okay, if you are asked in the exam, they will ask about the NICE. Okay, so recommendation of the NICE regarding the use of antibiotic: single dose of antibiotic prophylaxis intravenous on the starting of anesthesia. Regarding MRSA screening or carrier or prophylaxis, consider nasal mupirocin in combination with chlorhexidine body wash before procedure, in which Staph aureus is likely to be a cause of surgical site infection. So if you have any MRSA, okay, prophylaxis, or you are dealing with a carrier, remember the nasal treatment with the mupirocin and chlorhexidine body wash. Skin preparation, surgical site infection, use alcohol-based solution of chlorhexidine. So NICE like the chlorhexidine. If they ask you about before surgery, betadine or chlorhexidine, which one you will go? Chlorhexidine. Actually, nobody now uses the betadine. So, or aqueous solution of chlorhexidine if operation next to mucous membrane. Alcohol-based solution of butadiene iodine if the chlorhexidine is contraindicated only. Okay, guys? So this will be in case of chlorhexidine is contraindicated, like for example, the patient has allergy or something. Preoperative skin wash. Shower or bath using soap either on the day before or on the day of surgery. So we will advise the patient to have a bath with the chlorhexidine. Chlorhexidine antimicrobial soap is available in everywhere. So it's easy, cheap, and effective. Patient hemostasis. Okay. Maintain temperature in line with the NICE guideline. Maintain optimal oxygenation during surgery. In particular, give patients sufficient oxygen during major surgery and the recovery period to ensure maintenance of hemoglobin saturation of more than 95%. They didn't comment on vaginal cleaning. Regarding hair removal, NICE guideline advised don't routine hair removal routinely. Okay? If hair had been removed, use electric clipper with a single-use head on the day of surgery. Okay? Don't use razors or shaving. Skin closure. Consider using suture rather than staple to close the skin after cesarean section to reduce the risk of superficial wound dehiscence. Clear, my friend? Please, my friend, for a patient who had high risk of infection or they have very high BMI, remember negative pressure wound therapy. Okay? Negative pressure wound therapy, it's like routine in such patient. Okay? Risk factors, okay, as you know, this is everybody know it, okay? Like for example, age, obesity, diabetes, smoking, okay? Contaminated surgery, presence of pre-surgical infection, all of this. But here, my dear friend, this table is very, very important for your exam. Okay, so people who ask about any collection for antibiotics that we can use, this is a one that we advise, please. Okay. Dr. Noha, she's asking what is the negative pressure wound therapy. Okay. I'll show you a picture there of that. Okay. So 1 second, for some reason it doesn't want to open anyway. Okay, can you see this, my dear? I'll send you the picture on the group, okay? So it's something modern, okay, which is widely available in the UK, especially for obese patient or when there is risk of wound dehiscence or after treating complicated wound, okay? So the negative pressure will be effective to prevent the infection, okay? Okay, so let's go back, guys. Yes, of course, KSA actually is more rich than the UK and the whole Europe, to be honest, mashallah. So they have the facility to use everything. So dear, suggested recommended prophylactic antibiotic for obstetric and gynecology surgery. Cesarean section. Combination is important, okay? So either cefazoline or cefurexime plus metronidazole. In yesterday question, there was cefazoline but with wrong combination. Do you remember? This one is suitable, or this one with the metronidazole. Abdominal hysterectomy. You can use either IV cefazoline or IV cefurexime plus metronidazole or co-amoxiclav. Okay? So the co-amoxiclav can be used in abdominal hysterectomy but not cesarean section. Vaginal hysterectomy, same advice. Okay? Perineal procedure, IV cefirixime plus metronidazole or co-amoxiclav, followed by oral co-amoxiclav 8 hourly for 5 days. Okay, guys, this is to reduce the risk of infection. MRSA positive patient. Remember, teicoplanin plus gentamicin. Notes about allergy. For cesarean section, if the patient had allergy, okay, like penicillin allergy, then clindamycin plus genta. For abdominal hysterectomy, clindamycin plus genta. For vaginal hysterectomy, penicillin allergy, then we will use clinta plus gentamicin. Okay, this is a very good replacement because it replaces all other types of the antibiotic, right, in this procedure. How about perineal? Okay, perineal is gentamicin plus metronidazole followed by oral clindamycin. This is if the patient had perineal procedure but she had allergy from the penicillin. So genta plus metronidazole followed by clindamycin. Are we clear so far, guys? This table, you need to have a look. If you did not study it before, please do it now. If the surgery is prolonged more than 3 hours, do I need to increase the dose of antibiotic? Yes. Okay. So if the surgery is prolonged more than 3 hours and blood loss is more than 1.5 liters, so for morbidly obese women, consideration should be given to administration of a higher or indeed double the standard dose of prophylactic antibiotic. For example, the standard dose of cefazolin is 2 grams, but for those who weigh more than 120, this should be 3 grams. In special cases such as obstetric and gynecology patient with cardiac condition, okay, the thoracic valves and the transplant surgical prophylactic antibiotic regimen are not usually different. It must be remembered that they are not recommended in clean or non-prosthetic uncomplicated surgery such as diagnostic laparoscopy, ovarian cystectomy for uncomplicated simple cyst, or laparoscopic sterilization. Okay, so this is a question mainly of part 3 exam and oral exams that they will ask you, okay, about laparoscopic diagnostic laparoscopy. Do you need antibiotic prophylaxis? Not routinely, okay? Prolonged post-operative prophylactic antibiotic is associated with development of antimicrobial resistance, so it is not advised unless there is a need for that. Antibiotic-related morbidity and increased healthcare cost, it's therefore not recommended unless there is specific indication. Okay, my friends, are we clear here so far? Okay, so if you ask me, my friends, about what is the importance of this guideline, okay, I'll tell you that, sorry, this talk article again. They ask some questions about the microbiology. What is the most common species in this? What is the most common bacteria in that? Okay, so this is very important for you because it's a basic knowledge, very common to come in part 1, but if it come in part 2, people will really forget. Okay, so please have a read and refresh your information. Then after that, have a look to the advices before surgery or advices of treatment of wound infection already. Okay, as I told you, it's important for part 3 more than part 2, but however, you need to read it. It will be also useful for you in your practice. Regarding the recommendation, okay, for prevention of surgical site infection, focus on the NICE guideline, please. Okay. Regarding the antibiotic, it's super important to know what is the antibiotic regimen in each case. This table, the last one, table 4. Okay, friends, are we happy so far? Okay, so the next 2 articles that I would like to revise with you, okay, as I promised yesterday, we need to revise the 2 article of the safety of medication in breastfeeding. Why it's a safety. So whenever we have a safety, we must be safe, and it will be tested in the exam. Whenever, guys, you have a problem or in remembering the doses or the type of the drugs or something like that, please keep the notes with you till the exam day. Okay, please. Okay, so what you will do is revise it frequently from now. On the day of the exam, make it like very handy. Okay, have a look, okay, before exam to the common algorithm, especially the newest one or the most important one. Okay, guys. And from the thing that you need to revise, tables like this. Okay, so types of medication. Analgesic. Preferred drug during breastfeeding is paracetamol. Ibuprofen can be okay. Dihydrocodeine is okay. But which medication that you would like to avoid? Codeine, phosphate, and sulfate. Okay, so codeine should be avoided. In part 3 exam, they had one case scenario, okay, while she was using codeine for pain relief and she's breastfeeding. They were testing this in the safety of the candidate. So the candidate who didn't advise her to stop the codeine and change it to something else, safe during breastfeeding, failed safety. Okay, so please take care. Antibiotic. Coamoxiclav, safe during breastfeeding? Yes, why not? Fluoxetine safe? Yes. Metronidazole safe? Yes. Ciprofloxacin will be safe for short term only in cases actually where there is significant harm to the mother. Okay, so and by the culture and sensitivity, only ciprofloxacin, so give only for this duration, short duration. How about nitrofurantoin? Nitrofurantoin should be avoided in patient or babies with G6PD deficiency or first week of life, less than 8 days. Okay? What is the antidepressant that can be safe during breastfeeding? Actually, it's safe also during pregnancy. From the SSRI, sertraline. And the sertraline is the one preferred in the breastfeeding because of the less amount produced in the breast milk. Okay, my friends? Antihypertensive medication. From the ACE family, only enalapril is allowed by the NICE. If the patient is having hypertension postpartum, she can use the enalapril, but not other ACE inhibitor. Remember also that it will be avoided in severe cough cases, the famous question in the exam. Nifedipine safe or not safe in breastfeeding? Yes. Labetalol, atenolol? Yes, why not? So, in breastfeeding, we avoid diuretics, other ACE, or ACE other than enalapril, and angiotensin receptor blockers, same like pregnancy. Okay, my friends? Steroids are safe during breastfeeding. Antiepileptic medication. Okay? Avoid or have caution with phenobarbital and primogene. Contraception. Safe, right? Remember, ulipristal acetate, only breast milk should be expressed for how many? 7 days. Okay. How about CUC after delivery in breastfeeding woman? When to start CUC in breastfeeding? After 6 or from 6. Okay. Here is a key message for painkiller. And painkiller also important in your exam. So codeine had a very weak analgesic activity. Its analgesic properties are provided by its metabolites. Okay, it's considerable genetic variability among patients in both enzyme required to metabolize codeine. This can result in varied response actually and varied amount of drug in the breast milk. Okay, an exclusively breastfed infant would receive an estimated 1% of the maternal weight adjusted dose. Maternal codeine use also be associated with asymptomatic bradycardia, apnea, or cyanosis in infants. So please, please, for safety, advise against. Codeine and tramadol can increase serum prolactin. However, the prolactin level in mother with established lactation may not affect her ability to breastfeed. UK Medication Information Support, which is called UCAMI, supports the use of dihydrocodeine in breastfeeding women at the lowest dose for shorter duration. Okay. Excretion of tramadol into breast milk is low, and even lower amount of its active metabolites are detected. That aspirin is not advised to be given to infant or children, right? So, Reye syndrome has been associated with aspirin given to infant for viral infection, but its association with breast milk is unknown. The occasional use of low dose would not be expected to cause any increased risk in breastfeeding infant because only small amounts are known to be detected in breast milk. Therapeutic dose of morphine, for example, post-operative analgesia, are unlikely to be harmful in short duration. Women who were prescribed any medication were found to have approximately twice the risk of delayed lactogenesis compared with women who had no analgesia with spinal or epidural. Antibiotic key message also in this TUG article. Coamoxiclav, considered safe, broad spectrum antibiotic. Fluoxetine remains safe in breastfeeding mother. Okay? Metronidazole can be associated with candida infection and diarrhea. Okay? Topical ciprofloxacin, safe or not safe? Topical means eye drops or ear drops. Safe. There is a study nowadays, okay, that didn't prove the harm of ciprofloxacin. However, as I told you, it's absolutely, we use it when it is absolutely necessary for the mother health for short duration. It has been previously stated that doxycycline is contraindicated during breastfeeding owing to possible staining of the infant teeth or bone deposition or of the tetracycline. However, available literature suggests that short term is unlikely to be harmful because low level are present in breast milk and absorption by the infant is inhibited by calcium in the breast milk. So in the doxycycline, okay, short-term use is unlikely to cause harm. Trimethoprim or nitrofurantoin are preferable to ciprofloxacin for routine urinary tract infection in breastfeeding. Nitrofurantoin is contraindicated for use directly in infant under 1 month old and in those with glucose 6-phosphate dehydrogenase deficiency because the potential of hemolysis risk is greater than with this G6PD, okay, as soon as 8 days after delivery. It's thought to be safe to use while breastfeeding outside these times. Vancomycin is poorly absorbed orally and it's unlikely to reach the bloodstream of the breastfeed infant, so it's safe. Teicoplanin is not orally absorbable and also does not affect the breastfeeding. For anxiety and depression, sertraline is selective serotonin reuptake inhibitor of choice. It is not recommended to stop fluoxetine for breastfeeding, okay? But if it is needed for the mother to control the mother symptoms and the woman is already stable with the fluoxetine, so she needs to watch the baby, okay, for side effect and adequate weight gain. Transfer to infant in breast milk is relatively high, so no adverse outcome has been reported, so it can be safely used. About the direct oral anticoagulant, not currently recommended as first-line treatment for venous thromboembolism in pregnant or breastfeeding women because there is paucity of safety data, okay? Complex medical problem. Okay, breastfeeding can continue as normal with short courses of high-dose steroids, okay? Some evidence suggests that the levetiracetam might reduce the breast milk supply in some women. Prompt serum monitoring of lamotrigine and dose adjustment are necessary after delivery because maternal serum levels are increased in postpartum. In contrast to pregnancy, sodium valproate has a reassuring safety profile and can be recommended during breastfeeding. Okay, guys? Antihypertensive key message. I am sorry, I know that this article is long. First-line treatment of hypertension in breastfeed is enalapril, okay, and nifedipine for Black African or Caribbean family origin. No adverse effects have been reported in infant exposed to nifedipine in breast milk. Enalapril is poorly excreted in breast milk. As a result, it's not expected to cause any side effects in exposed infant. It is recommended the breastfeeding woman avoid diuretic or angiotensin receptor blocker. So those questions, my dear friends, they are from the NICE guideline of hypertension. However, it's collected here. If the woman had ineffective medication, so we can add atenolol or labetalol. Contraception key message. Lactational amenorrhea can be effective up to 98%, right? But the criteria should be met that the woman is fully breastfeeding both day and night, infant is younger than 6 months old, and the woman is amenorrheic. All other circumstances, contraception is required from day 21 postpartum. Breastfeeding women are safe to use the following method from any time after birth. Progesterone only pills, contraceptive injection, okay? But be careful if given within 6 weeks of delivery, woman will likely to experience heavy and irregular bleeding. From 6 weeks, woman can use the combined oral contraceptive or the patches. Okay, friends, are we clear so far? Okay. So hopefully that our discussion today was somehow useful to all of you guys. I love you too, my dear. Thank you very much for the nice words and the compliment. Okay, guys, study well. Revise the most important topics, okay, along with the tricky ones or the new ones. Okay, so it seems that I have to go now. Thank you very much.